We are live now, doctor.
Okay, thank you. So welcome everyone to our late night episodes yet again, and this would be our 30th episode correction for the initial invite which we had sent. The whole focus about the next 3 to 4 episodes would be on macular edema, especially diabetic macular edema, which I want to emphasize on. Thirdly, we'll possibly having a module of this. So we'll be having one session based on medical, second on surgical, third on atypical DMEs related diagnosis, and fourthly, we'll have possibly have what do you call a master class from a senior person. So I think we can start the session. And for the session today, we have our host, Dr. Bhavik Panchal. He is currently the consultant at LVPI Vizag. And over to you, Dr. Bhavik, and all the best for this session.
So thank you so much, Dr. Onish. So guys, we are back. We are back with a bang with the latest season of Late Night Retina. This is our episode 30. And with me, I have a whole lot more new episodes, new content, and new panelists, new presenters as well. So today for the presenters, we have Dr. Aarti, who is a VR consultant at Rajan Eye Care Hospital, Chennai, and Dr. Afra, who is a fellow with us at L. Prasad Institute in the Visakhapatnam campus. Joining us as a panelist, Dr. Madan Gopalan. He's a consultant at JB Hospitals in Salem. And Dr. Samendra Karkur, who is the assistant professor at AIMS Bhopal. And our very own Dr. Chitranjan Mishra, who is a VR consultant at Trilochan Netralaya in Sambalpur in Odisha. So he is also the managing director, the MD and the chairman there. So over to you, Dr. Aarti. So this, as Dr. Avnish mentioned, we are going to go ahead with diabetic macular edema, medical management, and associated complications like cataract or some other atypical edema as well. Go ahead, please.
Very good evening to one and all. I hope my slides are visible and I'm audible.
Yes, you are.
So I would, at the outset, I would like to thank Team Yosi, especially Dr. Avnish sir, for giving me this opportunity. So today in my presentation, I'm going to be sharing our experience of 3 cases where the patients had significant cataract and diabetic macular edema, and we treated them with intravitreal injections at the same sitting as cataract surgery. So over to my first patient, who was a 65-year-old male, with a known history of diabetes for more than 15 years and hypertension for the past 5 years. So he was basically a one-night patient with history of laser being done for proliferative diabetic retinopathy outside. And when he presented to us, his systemic conditions were well controlled. So on examination, we found that he has NS1 to 2 cataract and his visual acuity was 618. Fundus showed stable lasered proliferative diabetic retinopathy with no active NDE or NVD. OCT showed a thin ERM with cystoid spaces at the macula, with center involving DME. So we proceeded to treat him with 3 doses of injection ranibizumab as the first line at monthly intervals, which showed very minimum to nil response to injections. By the time he took the 3rd dose, there was also a history of fluctuations in his blood sugar, and his vision had significantly dropped compared to that at presentation. So we decided to go in for the dexamethasone implant with adequate systemic control. He showed significant improvement at 1 month post injection, where his visual acuity improved to 6/9 Snellens. But at 3 months, we saw that the edema came back, where his vision again dropped to 636. When we suggested him to undergo a repeat injection, when he was lost to follow-up due to some personal reasons and presented to us 6 months later, which was 10 months since the time of injection of the DEX implant, with the cataract progressing to stage 3 nuclear sclerosis and with a significant drop in best-corrected visual acuity. So this time we suggested him to undergo cataract surgery combined with the DEX implant, and he had a significant improvement in vision with the resolution of the cystoid spaces, which lasted for 8 months post cataract surgery. At the 9th month follow-up, his vision again dropped to 618. So we had suggested a repeat DEX implant. He had taken it recently, some 10 days ago, and when he had reviewed for his IOP checkup 2-3 days back, his visual acuity had improved to up to 612. We did not repeat OCT at that visit, so I have not added it here. So coming to our second patient, this patient was a 75-year-old male with a known type 2 diabetes mellitus and hypertension. He had significant visual disturbance, and his best corrected visual acuity was 624 and in the right eye and 636 in the left eye. He had a previous history of getting treatment with ranibizumab biosimilars. He had taken 3 monthly doses, which was some 6 months apart. So his last injection in the eyes were almost 6 to 7 months prior to when he presented to us. And his systemic control was under good state when he had presented to us. But he had a recent history of coronary artery disease for which he had undergone CABG 4 months apart. So his vision at presentation was 660 in the right eye and 624 in the left eye with significant cataract changes. Actually, initially we had suggested him to undergo cataract surgery with dexamethasone implant for both the eyes. But due to some financial constraints, he wanted to undergo the right eye first. Where for the right eye, we took him up for cataract surgery with DEX implant. And the left eye, again, due to financial constraints, he came back only after 6 months. He wanted to do the surgery. By then, he was cleared by his cardiologist for the ranibizumab biosimilar. And considering that the edema was also very less, not much increase in thickness, we did ranibizumab biosimilar for the left eye. So first presenting the findings of the right eye, which underwent the procedure first, he seemed to do well with one DEX implant, and now the right eye we have up to 1 year of follow-up, where still his fovea is dry, with where he is maintaining 6/9 vision in the right eye. We did not need any further injections. The left eye, which was operated 6 months later, also seemed to improve well with the ranibizumab biosimilar. At this point, his systemic status is very well under control. He's only on oral hypoglycemic agents. He's being stopped insulin. So now, as of now, he is having 6/9 vision in the right eye and 6/6 in the left eye, and he is pending for further follow-ups. Next, coming to our third patient, he was a 54-year-old male who was a known case of diabetes, hypertension, and hyperlipidemia with almost good control for the past 10 years. He also had a recent history of CABG, but that was 9 months ago. He had not been previously screened for any kind of eye problems. And when he presented to us, his BP was quite high. It was around 190, 110 and sorts. So his visual acuity in the right eye was 6/9 and left eye was 636. So the both eyes had around NS 1 to 2 lens changes, and the left eye had significant macular edema. So we decided to observe the right eye, and we asked for systemic control. And when he reviewed with good systemic control, we took him up for cataract surgery combined with injection aflibercept after clearance from his cardiologist. So his vision, there was significant improvement in vision despite persistence of CME in the left eye. It was improved up to 6/9. Now he is 3 months post-injection aflibercept. Except for few cystoid spaces, he's doing well with a visual acuity of 6/7.5. So as of now, we are just putting him on topical NSAIDs. We are not repeating any injections because the patient is satisfied with his vision. The right eye is also maintaining vision, its status quo with 6/9 vision, and he's developed only few cystoid spaces, which also we have again maintaining with topical NSAIDs. So with this, I would like to conclude my presentation with few questions I have for the esteemed panel. So is there any role for perioperative NSAIDs in the management of diabetic macular edema and cataract surgery? Especially in my second patient where the macular edema was very, like there were only few cystoid spaces. Would that patient have done well with just perioperative NSAIDs, which was started pre-op and post-op? Or any edema, however trivial we see before surgery, does it need to be addressed using an injection? And though we manage these three cases concurrently, what is the preferred timing? Is it before surgery or after surgery or along with surgery? And if we decide to do it on a separate sitting, what will be the ideal time intervals? And of course, it comes down to what drug we'll be preferring for which patient. Thank you.
Yes, wonderful, wonderful. Dr. Aarti, that was a very lucid presentation of the three cases. And that too the cases were quite different from each other, where one received dexamethasone, other received a biosimilar of ranibizumab, third was managed with an aflibercept. So, Doctor, Aarti, I want to ask you this question. So, do you routinely give topical NSAIDs after cataract surgery for your patients?
No, sir, we do not prescribe them routinely. We give them under selective circumstances, like he is a previously treated case of macular edema due to some other cause. And so we do not want it to recur, or there has been an intraoperative complication like a PCR or use of iris hooks or prolonged surgery. In those cases, we do not add for all cases.
Okay, wonderful. So we have different practice patterns. I'm going to open with this question itself because this is very common practice, and there is no unanimity amongst the practitioners whether to use NSAIDs or not, perioperative or post-operative. So I'm going to start with Dr. Madan actually with this question: that do you believe in prescribing topical NSAIDs perioperative or post-operative, or you do not use it at all?
In my cataract surgery practice, I don't use NSAIDs as a routine. But when I think that the patient is a little more predisposed, for example, I see microaneurysms close to the fovea, or the patient has had a similar episode in the other eye, then yes, I would probably be thinking of pre-operative and post-operative NSAIDs, but otherwise not as a routine.
Okay, so you mean to say when you see DME or you see microaneurysm, NPDR changes, you will prescribe NSAIDs. And a very important role you brought about the other eye. We'll come back to that point of other eye developing CME. So, Dr. Samendra, what are your thoughts on the same question? You are muted, Dr. Samendra. Just before that, just 1 second, I will request all the viewers on YouTube. The YouTube comments are off for some reason. So please join us on the Zoom link and ask your questions here. Okay, yeah. Yes, Dr. Samendra.
Okay, so I think what you want to ask is that whether the use of NSAID is there in
your practice.
In my practice.
Yes.
So basically, I don't pre-treat them with NSAID. I always give NSAID in all my cases of cataract surgery post-operatively in diabetic patients. And any patient who has any grade of NPDR, especially the ones who have center involving or non-center involving macular edema. So all of my patients, they get steroids with NSAID post-operatively.
So it's irrespective of the diabetic macular edema. If there is diabetic retinopathy, you prefer giving NSAID.
Yes.
Okay, that's a different way of treating, a different protocol that we got to know. We'll go back to Dr. Chitranjan. Dr. Chitranjan, what are your thoughts on audio practice?
Yes, so yes, I just want to slightly differ from my previous two panelists. So basically, we should think in the other way whether there is an increased risk of DME or postoperative CME in the patients who are undergoing cataract surgery who are diabetic, not having DR, or diabetic having diabetic retinopathy. Correct. So I was just going through one of the papers in ophthalmology 2016, little older one. But there they have written nicely that diabetic patients with no DR having high risk of new DME close to 2 times higher risk. Diabetics with pre-existing DR even higher risk, 6 times more risk of development of DME. And post-operative CME, when we see angiographic CME, the risk also is higher in the eyes, those who are patients having diabetes, either having diabetic retinopathy like mild moderate NPDR or not having diabetic retinopathy. So based on these findings, I just through another current opinion ophthalmology 2019 paper, there they have written, as the previous speakers, previous panels, they actually told that Madan and Samendra. So they have given preoperative intracameral also they have given mydretic plus NSAID drugs and postoperative. And that conclusion was that this helps, like the use of perioperative or preoperative NSAIDs really helps in the reduction of the postoperative DME and even postoperative cystoid macular edema. So where I do practice, my cataract colleagues, they routinely give a kind of NSAID for all the patients, those who are having diabetes, irrespective of diabetic retinopathy and undergoing cataract surgery.
Yeah. So this forum here is not to change anyone's practice pattern. The idea is to present evidence to everyone that, okay, this is the scenario, and then one can have a educated approach towards it. So as Dr. Chitranjan mentioned that, so this is the statistics that natural history of macular edema after cataract surgery in diabetics. If there is no DME, there is a progression chance of 10 to 22%. Okay, at 1 month interval in patients with diabetic retinopathy. Okay, whereas there is a resolved DME, when the DME is treated, still there is a chance of 24-30% that the progression of edema is going to happen. And if you have diabetic macular edema and you are going to operate the cataract, the chance can increase to 20 to 50% as well. So I thought I'll share this slide of what Dr. Chitranjan was mentioning. Wonderful. So with this, I think we come to the next point about, so Dr. Aarti, in your presentation, you had a patient undergoing surgery along with Ozurdex, and subsequently in certain other patients, you had surgery which was done prior and post as well. Surgery was done prior and then injection was advised. So I want to start with Dr. Samendra here, or maybe Dr. Afra. When you operate a patient who is having diabetic macular edema, so suppose you treated the edema before, okay, few months ago. Now the patient needs cataract surgery. What is your practice pattern in such patients? Along with the cataract surgery, do you inject anything?
So, like we do inject if there is no edema also, like triamcinolone acetonide.
Okay.
Yeah. So, like, sorry. Yeah, steroids.
Steroids. Okay. So I think that is an interesting debate here between anti-VEGF and steroids. What we heard from Dr. Aarti as well. Several cases had anti-VEGF been injected, and we saw that even after 3 months of aflibercept, there was no recurrence of edema. And Ozurdex also was giving good results. So we'll start with Dr. Chitranjan here. Okay. What is the right approach here? Or I'll not say nothing is right or wrong, but what do you think is preferable, doing the injection prior and taking the patient up for surgery subsequently, or the other way around?
So, see, Vivek, here actually the grade of cataract plays a major role in this. Say, if I see the cataract is little, say NS1, 2 kind of thing, it does not really, it has gone to a very mature stage. So, in that case, the preference is injection, so that even little clearer we can show to the patient. And after 1 month, when the edema resolves, the patient also gains some confidence. Then probably the cataract progresses, we take for cataract surgery. But if the cataract is really NS2 or something, we need to knock it out. Definitely, the cataract needs to go. I prefer cataract surgery with injection in the same sitting, if at all the patient. So here actually, because we are discussing nothing like black or white, we are discussing gray zone, we need to discuss with the patient also. The patient needs to also understand what is going to happen, and that is the thing. And regarding the injections, should I tell now, or which is the preferred thing in which OCD biosimilar, or you are going to ask later?
We'll listen from the other panelists as well. So
okay, so this
Dr.
was my thing.
Yeah. So Dr. Samendra, what is, like, do you also follow the similar thing, or Dr. Madan, do you do something different to what Dr. Chitranjan mentioned? And Dr.
So
Madan,
I'll go
yeah.
first.
Sure.
Basically, what I should I go first?
Yes, go ahead.
Okay. So basically, in my practice, what I see 2 types of patients. One who have just come for cataract surgery and sugars are not controlled, and the cataract is so mature that you can't see the fundus.
Yeah.
So now all I need to do first is get their sugars under control, give them NSAIDs, and then do the cataract surgery. And later on, whatever I come across in the fundus, I treat accordingly. If I come across macular edema, we treat accordingly. The other group is patients who you can see the fundus and they are on an active anti-VEGF regimen. So I will time their cataract surgery somewhere in the peak of anti-VEGF effect. But if the sugars are uncontrolled, cataract is operable grade 3 to grade first, control their sugars, give them NSAIDs, and then definitely treat the patient with anti-VEGF first, followed by cataract surgery, and then anti-VEGF regimen accordingly later. Because the patient has to be in a proper patient has to be primed for cataract surgery. Otherwise, cataract surgery is only going to worsen the edema. The visual outcome is not going to be adequate, and it is not going to be a happy patient.
Yeah.
That's about it.
Yes. All points taken well. Yes, Dr. Madan Gopal. Any other different point of view?
I would prefer to actually treat the DME first. So now there are a lot of social and logistical issues. So I practice in a private center where a lot of referral comes in. So suppose the patient is my own patient and I am going to do the cataract surgery. I would prefer to give an injection a week or two later, I'd go for the cataract surgery. But suppose the patient is coming from a different center where he's going to get the cataract surgery done there, then I would say you get your cataract surgery and then come back to me.
Okay. Yeah, makes sense. So I think all of us agree that treating the DME first, if at all, if it's visible and the patient is not, it's treatment naive, that is the correct way to go about, except unless you have a very hard cataract, patient has bilateral cataract and visually handicapped, then that's a different case altogether. So Dr. Samindra mentioned a very important point here about good DM control. So Dr. Aarti, in your setup, like how do you define a good DM control? Any experience?
We particularly have the practice of referring all the patients to the diabetologist at the point of diagnosis of diabetic retinopathy. So we are specifically emphasized to communicate to the diabetologist either through a written letter or a phone call asking for significant control of not only diabetes but also hypertension, hyperlipidemia, renal parameters, hemoglobin and stuff. So we do not decide if it is an adequate control, because certain patients, they typically tell if their sugars go below 200, they feel hypoglycemic. So we make the physician certify that the control is adequate or inadequate, and then we proceed with the treatment.
Perfect. No, why I ask this question? Because sometimes the HbA1c is on the higher side, right? And then sometimes it gets under control, but on the day of surgery or day prior, the sugars are 220, 230. So we know there are certain guidelines which are available which says that you should not operate beyond 200, 220. So Dr. Chitranjan here, I want to ask you, since we all are retina specialists and we know that for a diabetic it's extremely difficult to control his blood sugar levels and to have it in range, especially having CKD or undergoing dialysis. So what is your leeway? Where do you stand there? Okay. Do you consider 250 also is okay to operate? 260 is also okay to operate? What is your line? Where do you draw a line there?
See, I'll tell you, Bobby. I'll answer this question, but the magic number does not come like a particular number like that. But we must remember there are two situations. One is NBG, neovascular glaucoma with VH. Another thing is really we have a kind of lens-induced glaucoma or cataract catastrophe. I'm telling two extremes. In those cases, really the HbA1c, whatever it is high, even 10, 11 or something, that really does not matter. We need to intervene at that time. Okay. Apart from that, rest of the things we need to really control the sugar before intervening. So this is the line. And again, coming to what is the control. So usually we take it as say 200, 220 kind of thing, RBS, and HbA1c if you see 8 or something. So we need not wait for it to come to 6 or 7. We cannot, because chronically the patient has been at a very higher kind of HbA1c level. So sometimes 8 or 9 even it's okay. But RBS we need to kind of document, or sometimes people come with FBS, fasting blood sugar also. Like though 126 is officially what you should take it, but sometimes 140 or something we also take. That is the thing. Yeah.
I think Dr. Aarti's son is going to be the youngest retina surgeon. He is actively listening to our talks.
My
So I
daughter.
request, don't switch off your camera. Let him listen to us. Yeah. So I think a good, interesting points are coming up here in terms of good DM control is essential. Injecting before cataract surgery, topical NSAIDs, most of us prefer to give after cataract surgery in spite of an uneventful cataract surgery. So the next point here, I want to little bit change the topic here in terms of the choice of anti-VEGF. Not just for okay, you know that your patient is having diabetic macular edema and subsequently will require cataract surgery at some point in time. Okay, so what is your pattern to start treating these patients, Dr. Madan?
So I presume this patient, you're talking about a patient who has treatable diabetic macular edema right away.
Yes, you
Yes.
can go for both because our listeners are both anti-segment surgeons as well. Everyone, all ophthalmologists will be there. So say center involving and non-center involving, and also going ahead with treatable DME as well.
Okay, so if the media allows me to treat the diabetic macular edema, my priority is to treat the macular edema by whatever means it is required. By which, if it's center involved, my first go-to choice would be a biosimilar. Non-center involved, I still prefer focal laser.
Okay,
And of course, if the media does not allow me to evaluate or treat the fundus, then of course get the cataract done and go ahead and do what is required.
okay. No, so I'm not focusing on cataract here right now, but I got your point for your answer. So Dr. Samendra, here I want again get back to you. Do you prefer loading doses if you are going for anti-VEGFs, or first of all, is your choice of anti-VEGF or steroids in a patient who is say treatment naive versus a patient who's already received multiple injections? I think you are muted, Dr. Samendra. Dr. Samendra, you're muted.
I'm sorry.
Yeah.
So basically, I keep it very simple. If I see a pocket of subretinal fluid, I combine my cataract surgery with steroids, preferably an Ozurdex.
Okay.
But if I see intraretinal fluid or perifoveal cystoid spaces, and then routinely I go with anti-VEGF. So it's very simple.
Okay, no, so I'm going to bypass the cataract now. I'm just talking about patient who you have operated now has macular edema after 6 months, 1 year,
Mhm.
versus a treatment naive patient who comes to you for the first time. Okay, then treat and the cataract is not much. So do you go with
Okay,
loading
so patient
doses?
develops macular edema. So if the patient again is a treatment naive patient, I would go with anti-VEGF.
Okay,
And if the situation allows, then what I do angiography. I do angiography in all my patients of NPDR. So that allows me to assess the CNP areas. So if I see that there are lots of CNP areas, then I would go with anti-VEGF. But but CNP areas are not that much, and it's basically the microaneurysms and all those things which are leaking, or there's a diffuse leak at the posterior pole, and there is a pocket of SRF, then I would go with steroids. So this is a very simple differentiation that I keep when I choose between steroid and
okay,
anti-VEGF.
great. So Dr. Chitranjan, coming back to you, we know that there are multiple biomarkers which are predictors for a good visual prognosis, poor visual prognosis. So whenever you select an agent to treat, say a steroid or anti-VEGF, uh, what are the biomarkers that you really consider in the real world scenario?
Okay, correct. So first of all, we should see the Otani classification that all of us we know about the types of morphological types of DME, say diffuse spongiform CME variety, neurosensory detachment with SRFD, and the tractional variety. So obviously the tractional variety is there, that biomarker will lead for surgery. And when you have NHD with SRF, as Dr. Samendra told, that one responds better to steroids. The initial two spongiform more than CME, they respond better to the anti-VEGF variety. And these are the categories what to choose. And when we are seeing obviously the prognosis, when we have hard exudates or say hyperreflective dots, then our kind of preference will be towards the steroids. And the biomarkers which predict a very bad outcome or kind of very guarded outcome, those are say outer segment ISOS disruption, adrenal, or say very large cystic spaces, which will define the chronicity and real degeneration of the kind of long-standing DME or chronic DME. So those are the biomarkers where we need to actually counsel the patient, that whatever treatment we are going to do, the kind of visual acuity may not improve that much. Yeah.
Right. So, what you're trying to say that biomarkers do play a role in terms of the prognostication of the patient and the treatment protocol as well. So, Dr. Samindra, coming back to you, good, you are unmuted. So, the choice of anti-VEGFs between the newer molecules like faricimab or brolucizumab or aflibercept, uh, will you consider them if at all you have this poor OCT biomarkers or OCT biomarkers predicting poor vision?
See, in a treatment naive patient, I wouldn't.
Okay.
So not in a treatment naive patient, but if the patient has had, say, recurrent injections of a particular molecule before, and if I have documentation saying that the patient has progressively responded less to a particular molecule, then I would
Okay. And Dr. Madan, same
upgrade.
question to you as
But not particularly, I don't go with any. So I don't go with the highest molecule available straight away in a naive patient.
okay. Sorry for that. I think there's some lag when you're speaking, so that is why I could not catch you.
Oh, I'm
Yeah,
sorry. I think
no
there is
problem.
an issue with the net. Yeah.
No problem. Yes, Dr. Madan. Yeah.
Yeah, absolutely. So see, the discussion is we're going to decide whether the patient requires an anti-VEGF or a steroid.
Yeah.
So if I see a lot of inflammatory markers, by
Yeah.
which I mean neurosensory detachments or HRF
Yeah.
and a sign of chronicity, then I'm going to shift towards the Ozurdex. Whereas if it's going to be if those markers are not there, then anti-VEGF would be my drug of choice. Again, when you talk about anti-VEGF, it's basically what Dr. Sarmendra was saying. It depends on whether the patient is treatment naive. If he's treatment naive, I'd go with the basic one, which is a biosimilar that I would prefer. If he's already treated based on what he's treated, so kind of switch the anti-VEGF.
Wonderful. I think Dr. Aarti, in between, you made a point about the financial aspect of the patient, right?
Yes.
And could not afford Ozurdex and all. So, do you consider triamcinolone acetonide into a practice?
We do not have the protocol of injecting triamcinolone for paying patients. So we do use them for our trust-based patients. We
Okay.
normally do not consider it for our paying patients, only under very rare circumstances we have considered.
Any particular reason for that?
The previous place where I did my fellowship, of course, we used it very frequently, but here the institutional protocols.
Sure, no problem. Let's not go into it. So, but I want to ask this question to all three of all the panelists here, Dr. Samendra, Chitranjan, Dr. Madan as well. Do you have you used triamcinolone? Do you use triamcinolone in the practice? Because I feel that it's first let us listen. Let us hear from you. Yeah, Dr. Chitranjan first.
Today,
Yeah.
yeah. So yes, my answer is a big yes. See, IVTA, you can tell it is a poor man's Ozurdex kind of thing because as the financial things are coming on, so we do get patients where actually steroid is needed, as we have discussed very nicely, and
Yeah.
there the patient cannot afford for Ozurdex. Fluocinolone is not present over here, so we are left with only triamcinolone, and so there what I do basically instead of 0.1 ml, I reduce it to 0.05 ml. That
Yeah.
means the 2 milligram
Yeah.
thing. And obviously, while we are discussing all the things of steroids, we need to keep in mind that the IOP, we should check it, and the any pre-existing cupping, high cupping, or families of glaucoma or anything, we should rule out all the things because the patients will be steroid responder. We see them not very infrequently, we see them. So after we have ruled out, yeah, and another particular indication I'll tell, though we have not come up with a publication, we have a good number of cases where we give combined injections, anti-VEGF plus this half dose steroid. But yes, because we have not come up with the publication, I cannot tell much in favor of like or against it. But the outcome is favorable in certain situations. So basically, what I mean to say that is I not entirely say out of the box or out of the armamentarium. It does help in
Yes. Wonderful.
some
Yes,
cases.
Dr. Madan.
No, I would 100% concur with what Dr. Chitranjan said. No additional points. Absolutely same.
Correct. And Dr. Samendra, do you also use it?
So yes, I do use IVTA, but then after I've exhausted all my other options,
Okay.
the only problem is that the patients keep complaining that we see a cloud in front of our eyes.
Yeah,
A
Yeah.
big
correct.
problem.
Yeah. Yes, I think we had an interesting discussion
So I have
on.
to really counsel them beforehand and prepare them for that this cloud is going to settle
I
down
think
in a
sorry
week.
again the lag. Maybe it's with your wallpaper there. It's taking up too much of memory.
I'll change that.
Yeah.
I'll
Okay.
change.
Maybe the last question here until we wrap up this session of DME and CAT and move on to the subsequent talk on for the next 20 minutes is that when do you consider? So we agree upon certain points that a good metabolic control, good DM control is extremely essential before you treat DME and even go for cataract surgery. And second point is that the role of topical NSAIDs, especially in diabetic patients, one should consider or one should read up and look at the evidence. The evidence is in favor of giving topical NSAIDs post cataract surgery for patients who have a diabetic retinopathy and so on. And also injecting before the surgery, if at all the view permits, and then you have a better outcome in managing diabetic macular edema. Choice of anti-VEGF. Anti-VEGF is the first choice in treatment-naive patients, even when after the good DM control as well. So the next question here is that maybe I'll start with Dr. Madan. So I have understood that for treatment-naive patient, you go ahead with anti-VEGF. But what is that point where you shift over to steroids, be it Ozurdex or be it Dexone implant or be it triamcinolone, or you don't shift your patient at all to steroids?
No, not really. 3 or 4 injections of anti-VEGF, which is not giving me the desired result on OCT or visually, then yeah, why not try something different?
Correct. I'll come back to Dr. Samendra as well. Why I'm asking this question because there's something called as patient fatigue as well. Even if they can afford, but to come monthly for injection, 2 monthly for injection, they get frustrated. So, Dr. Samendra, what are your views on that?
Yeah, we do come across these cases where after 2, 3 injections, they keep asking how long am I going to require injections. So when I sense that feeling that patient may not come to me as and when the injection is required, then I do offer them there is an option available which will keep you off injections for at least about 4 to 5 months. And if they choose that, I do go ahead with that.
Yes, and Dr. Chitranjan?
Yeah, I agree with Madan and Somendra that patient point of view. And in addition to that, when after even 3 to 4 injections, as Dr. Madan told that you are not getting the anatomical height reduction and hard grades are really there, or large cystic cavities are there, and there you actually need to change to Ozurdex. That thing.
Perfect, fantastic. Wonderful. I think we had a wonderful discussion, and thank you, Dr. Aarti, for those wonderful, brilliant cases as well. So, yeah,
Sorry, I just want to add one thing.
sure.
Like we discussed steroids versus anti-VEGFs,
Yeah.
but in between, I just add very for a small time. You told about the choice of anti-VEGF.
Yeah.
Do we really have something? Because what is my knowledge that protocol T only they discussed about aflibercept versus seranibizumab and bevacizumab, and it was 6/12 vision. Say if it is less than 6/12, that means 6/18 and further, their aflibercept was having little overrun. It was doing better than ranibizumab and bevacizumab. And 6/12 or less than like 6/9 or 6/6, they are all three were same. But nowadays, the scenario, I agree with Dr. Madan, a very important point that most of us, or at least I am using biosimilars very quite often, like 70 or maybe 60% of the injections are biosimilars. So any take on that, like any choice of anti-VEGF or biosimilar for any particular thing? I'm just asking.
No, honestly, I don't think there is any scientific evidence to choose from, to put it that way. So it would really go with the availability and the affordability of it.
Correct.
Yeah.
And probably the newer ones which promise for say 3 to 4 months, a longer duration, that only maybe the driving point. Otherwise, no kind of
Still a little
pharmacological
hesitant to use them as first line drugs. So, I don't know, maybe sometime in future that may be the norm.
Yeah.
correct.
I think we'll continue the discussion once we finish the case of Dr. Afra. So by the time Dr. Afra shares a presentation, the audience question was there, which we already answered. I'll repeat the question. When you combine injection with cataract surgery, before or after, or before or during surgery, tips to give injection before or after. So we agreed upon better to give injection prior to the surgery. And if you're doing during cataract surgery, after the surgery is a better time to give the injection. Anything special for Ozurdex injection and given simultaneously? ensure that your IOP is good once you finish the surgery, and you inject the drug in a not in a collapsed eye, not in a hypotenuse eye. That is what I'll say. Right then. So we move on to Dr. Afra. Dr. Afra is currently a fellow at Anand Bajaj Retina Institute at the Delhi Prasad Eye Institute in the Visakhapatnam campus. So yes, over to you, Dr. Afra. So the title is pretty interesting. Is it diabetic macular edema or not? Go ahead, please.
Thank you, Doctor. So a very good evening to everybody, and I would like to thank the panel for this wonderful opportunity. It feels very great to be here. So let me start. So today I have a case which raises the question, is this actually a diabetic macular edema or not? So we had a 49, are my slides moving?
No, they are not moving. If you move them, they are not moving. Yes, they are moving now.
Okay. Okay. So we had a 49-year-old male with a medical history of diabetes and hypertension in our OPD. His complaints was reduced vision in the only seeing eye since 1 month, which was the right eye. So his visual acuity in the right eye was 160 at the time of presentation. On anterior segment examination, he had an early cataract, and dilated fundus examination showed hard exudates arranged in succinate pattern with hemorrhages, as we can see here, along with macular thickening. And the left eye had microcornea with phthisis bulbi. So at this point of time, a diabetic patient coming to us with features of hard exudates and hemorrhages at the macula, our first differential, of course, will be diabetic macular edema for this retinal thickening. But can it be anything else? Like if you're considering the systemic status also, it can be CME because of any other causes like retinal vein occlusions, or it can be hypertensive retinopathy. Or if the patient was a pseudophakic patient post-surgery, macular edema can also be a like differential diagnosis. So keeping this in mind, we went on to do the OCT for this patient. So the OCT here, as we can see, there are multiple hyperreflective foci in the outer retinal layers, and there is a significant neurosensory retinal detachment at the macula. Usually in DME, we can see different structural changes, as we were mentioning the previous discussion, like sponge-like retinal swelling, cystoid spaces, or serous retinal detachment. Why do we see serous retinal detachment in DME? So one mechanism is that the external limiting membrane here in the retina is not impermeable to fluid and albumin. So when there is disruption of the inner blood retinal barrier, there will be excessive fluid accumulation in the subretinal space. And the RPE cannot effectively remove this, leading to the subfoveal detachment. And one more mechanism is the choroidal microangiopathy. So due to the ischemic changes, that there can be increased permeability of the choroidal vessels, leading to the subfoveal detachment. But we do see such kind of NSD, focal serous NSD, in CSCR also. In CSCR, the choroidal vessels become hyperpermeable due to impaired blood outflow, inflammation, or ischemia. And the mechanical stress and the choriocapillary hyperperfusion will lead to impairment of the barrier function of the RP, and it will lead to the RPE leakage and resulting in subretinal fluid. So at this point, we had another differential diagnosis, that CSCR. So in case of CSCR, this outer retinal layers can be normal in the acute cases, but hyperreflective foci can appear later in the chronic case or in recurrent cases also. So when we had a differential diagnosis of CSCR versus DME, we went on to do FFA for this patient. So as we can see here, there was a pinpoint leakage here in the early frame, which was increasing concentrically during the late phases. So usually in DME, there will be leakage from the retinal vasculature. It can be focal or diffuse. But in CSCR, the focal leaks will be at the level of RPE. And usually we see two types of pattern: ink blot pattern, which is more common, in which the leakage starts as a pinpoint area in the early phase and then concentrically enlarges in the late phase. And the another one is the smokestack pattern, wherein the pinpoint leakage will start in the early phase, but the hyperfluorescence will gradually ascend in the subretinal space, and then it will expand to form a mushroom cloud or umbrella-like appearance. So here we could see the ink blot pattern of leakage in this patient. So we came to a final diagnosis of right eye moderate NPDR with acute CSCR instead of diabetic macular edema. So we went on to treat the patient with focal laser to the leaking point. So 6 weeks later, this was the picture. His vision significantly improved to 20/40. And the NSD was very shallow at this point of time. So the differentiation between diabetic macular edema and CSCR has clinical significance because steroids,
I
like
think
we were
Dr. Afra,
discussing, considered as one of the.
yeah, we'll discuss that point about differentiation with the
Huh.
panelists. You can conclude the
Yes.
case. Yeah.
Like, hello? Is
Yeah,
it
go ahead.
audible, doctor?
Yeah, it's audible. Yeah.
So here we have differentiated from, in the starting we had a diagnosis in mind. We didn't have the diagnosis of CSCR in the mind, but later on with the investigation we had found out the cause of the leak and we have treated accordingly.
Yeah. You have further more slides? Any questions for the panel?
Slide? No, I have not put forward any questions for the panelists.
Yeah. No problem. Yeah, I think that's a very interesting case, a different take on diabetic macular edema. A lot of questions raised here, so I'll go jump in straight to the panelist here. We'll start with Dr. Madan Gopal in terms of how do you differentiate a neurosensory detachment or edema secondary to CSCR versus a TAB or a pseudophakic CME, like what we had in this case.
Right. My take is that, see, when you have a retinal vascular pathology, it's highly unlikely to have such a big subretinal fluid collection.
Yeah.
When I see a huge SRF collection, I mean, the volume of SRF is much more when compared to the intraretinal fluid. I'll be looking at disruption of the outer retinal barrier, and I'll be looking at leak coming in from the choroid rather than something from the retina going out and causing this bigger leak. So that would be very early sign for me to say, okay, this is from the retinal vascular circulation or from the choroid.
Yeah, I think so. You're relying on the OCT characteristics here, right? Yeah.
Yes,
Dr.
right away,
Samendra,
even before I go to the next one.
correct. So, Dr. Samendra, anything on the clinical aspect or on the angiography you will differentiate it?
Yeah. Dr. Bhavik, can you come again, please?
No, I was trying to ask Dr. Afra, you can keep your slide there. So the question was that rarely a patient can present with an atypical macular thickening. Like clinically, it can be like a pooling which is seen, or I'll not say pooling. Clinically, you can see a neurosensory detachment or a PED can be present as well. That can be mistaken for SRF. Okay, so these are different atypical forms clinically that we can see. So what I'm trying to ask you is that. Do you think clinically you can differentiate between neurosensory detachment because of CSCR or a diabetic macular edema in a patient who is having diabetic retinopathy, or will it be only angiographically?
So clinically, if a patient of diabetic retinopathy has developed CSCR, you will have something, some history or some medicine, something that he might be taking that can help you. Otherwise, looking just at the fundus picture, CSCR is absolutely like a blister. It is not going to be present like, like say, for example, this patient. So it's not going to be present like this. It's going to be absolutely clear-cut blister, and it is like on OCT you can make out like a tense kind of a SRF. Whereas if it is due to diabetic macular edema, it is not going to be as uniform, and I mean that's the only thing which I think helps. Otherwise, of course, we all do FFA to find out, but maybe that's the only clinical finding.
So, Dr. Chitranjan, if you can go back to the final slide, Dr. Afra. So we lasered this case. No doubt it's a case of acute CSCR. The remaining fluid here, do you think this is diabetic macular edema? Now will you give anti-VEGF?
No, I think it's a mixer.
Yeah.
It's a mixer. It's a combination. Mostly it was CSR because it has responded to that laser, which was not obviously a microaneurysm leak or something.
Yeah.
But just asking, you did not give any injection in this case. You left it like this? Or?
Yes.
So
After this, I do not know. Dr. Afra, what is the last follow-up for this patient? Dr. Afra, the
This
last
was the last follow-up actually. After this, we don't have, but we have not given any injection for this patient.
And after how many days or months of laser this photo is taken? 6 weeks only. 6 weeks. Then okay, this is very difficult. So we have to wait for maybe another some 4 weeks or something. It may resolve on its own. But again, very nice and very interesting case. As Dr. Madan told, it was the atypical elevation that led to FFA and the characteristic finding that led to CSR. But if I can come to your previous question, what you were asking, any particular biomarker which can lead to a suspicion of CSR, like there are some papers where they have told, the OCT, if you take through the leak, the suppose point where the leak is there is a hyper reflective structure RP near the RP with some hyper-reflective halo kind of thing. Some I faintly remember,
So
but
there is
that
a shrum, and within the shrum there is a hyper-reflective area.
yeah,
Yeah.
But in this case, it is so high, the NST is so big, it's difficult to tell actually. That's what. But very nice case. And as you have told, as you have done rightly, without giving any injection, we should follow for a few more weeks to come to a conclusion.
I think what Dr. Samendra mentioned about performing angiography at the baseline visit, I think that's a wonderful idea. Even I do it for most of my cases, and that brings out a different, lot of different similarities and asymmetric patterns also. And you are aware of that you're not dealing with just a routine DME. Sometimes you can have a lot of CNP areas. You can have peripheral avascular retina, and you can have arm to retina time which is deranged. So you may pick up a lot of things. So any thoughts on that, Dr. Madan Gopal, on performing?
No, honestly, my take is diametrically opposite. I don't do too many FFAs. I would rely on my clinical finding and the OCT. It's precisely because, what all you said can be there, the ischemic areas, peripheral non-perfusion areas, and all. But at the end of the day, the treatment that I'm going to suggest to the patient is not going to change much.
Yeah.
Yes, I can prognosticate, I can tell him this and that, but at that point of time, making a decision, it's not going to help me much. So if and when I see something atypical like this, yes, but not on a routine.
Okay, I think interesting point in the chat coming up as Dr. Kavita has asked about raised hypertension can cause SRF as well. So absolutely agree on that. Essential hypertension leading to hypertensive crisis or hypertensive emergency can also lead to disc edema, or may not be always disc edema, but peripapillary edema as well. So that has to be considered. But there are a lot of other signs, arterial attenuation, which needs to be taken into consideration as well. But I think that's a very good differential diagnosis here as well. So maybe I'll say that something which is hidden from, and people obviously don't go to it directly. We spoke about focal laser being done here. So I'm going to ask this question now to all the panelists. In this current era of anti-VEGFs, do you still perform focal laser or grid laser, modified grid, whatever you want to call it? I'll start with Dr. Chitranjan.
Yeah, so see, you have already answered the first part that anti-VEGFs take the bulk of the management. So we have limited scenarios. Again, coming to protocol V, where it has told that if a vision 6/12 or better, that means 6/12, 6/9 or 6/6, there if you do say laser or injection or observation, all three arms they performed equally. So we are left with very limited indications like say one single leaking say aneurysm, little away parafoveal say more than 1000 micron or something, where you can go and do a direct focal. But if you have access to yellow laser or micropulse subthreshold laser, where you can do a grid, that case you can, if you have a slightly diffuse edema, that you can give, because that is little, it's a cold laser they say, and it does not cause much say scarring or something. So those will be the indications. Otherwise, again, laser is having very limited role in this current era.
Yes.
Yeah.
So, Dr. Madan, you mentioned about non-center involving edema, you do perform focal laser. So you want to elaborate more onto that?
Absolutely. See, focal laser, I believe, still has a very, very strong role. And especially, this is one area where, you'll have to make the decision based on your clinical judgment. I don't think any other investigative modality is going to let you know that, this patient is a good candidate for focal laser, because the moment I see the patient in the OP in a 90D slit lamp biomicroscopy, I like to see where the retina is actually thickened and see if there is a culprit close by. So if I can make sure that this thickening is because of this particular leaking microorganism or a patch of leak, then definitely the candidate is a good candidate for focal laser. Of course, if the center is not in.
Okay, wonderful. And Dr. Samendra, I'm going to ask this through the same question to you as well. And then Dr. Arati. Once again, Dr. Samendra, you're muted. Dr. Samendra's love-hate relationship with the mic continues.
So focal laser for absolutely clear-cut microaneurysms which are leaking. And you know that once you are going to do focal laser, the edema is going to go away. Sometimes the only problem is that a single sitting doesn't work. You might have to do it 2 or 3 times. And if there is an area of ischemia, CNP areas on FFA, and there is a diffuse leak, then grid laser still works. Although we all are shying away from it, we just want to inject. But then if a patient is tired of getting injected, maybe you could give it a try. And like Dr. Chitranjan said, that yellow laser, if you have access to it, absolutely.
Yeah.
And I just want to add one more indication.
I'll come back to it. Dr. Chitranjan, I'll come back.
Systemically unwell, like very uncontrolled
Yes.
patients. That is one of the indications for laser.
Got it.
Yeah.
So, Dr. Aarti, if you have treated patients multiple injections and all, as patient is tired or as a recalcitrant edema, when do you consider focal laser or modified grid, that is focal plus grid laser?
So, sir, as you rightly mentioned, to reduce the burden of injections, at that point, we do repeat another FFA to see the leaking microaneurysms, and we do treat them. We have access to both green and yellow micropulse laser, but we normally prefer green lasers for this. To reduce the number of injections, and certain scenarios where sometimes the patients are not fit for injections, extremely poor systemic control. By some time in certain situations, we have gone ahead with focal lasers. And regarding the OCT biomarker, I just want to add one point. There is also a retinal tipping sign which can indicate that the fluid is more towards CSR rather than diabetic macular edema or hypertension associated SRF.
Okay. So we have maybe 3 more minutes left, and maybe a mono word answer or 2-word answer. Micropulse laser for DME, yes, no. Dr. Madan.
Well, the last time I used it was my fellowship, so I have no idea.
Okay. Dr. Chitranjan.
Yes, agree. I don't have currently it, but during fellowship time we have used very extensively.
Does it work? Does it not work in your hands?
Yeah. As I told, it's it's a gentleman kind of thing. So very aggressive edema and all, it will not work definitely.
Yeah.
But it has advantage over the traditional laser that you can go more closer to the fovea. But remember, in the machine setting, the micropulse kind of thing should be it should be on, not off. We have seen people having that has happened.
Yes. Dr. Samendra.
I don't have personal experience, but what I've heard from my friends, it doesn't work as well.
Yes. So there are mixed thoughts as we have in the panelists here as well. Yes, I think one more question is coming up. In more or less we have answered, but maybe we can for viewers we can have that. What are the indications of FFA in the current era of DME? So as we all know, to do the laser, perform the laser for the patients. Apart from that, any of the panelists or any of the speakers would like to add to this question? Indications for FFA.
When the visual acuity is not corresponding to the extent of edema, to rule out ischemic neuropathy, we normally.
Perfect. So we have macular ischemia. Second reason we have 2 for guiding the laser. Yes. Any other points?
And sometimes when there is asteroid hyanosis and we don't have a satisfactory view, that time also we tend to.
Yes. And when you want to rule out ocular ischemic syndrome, then you have asymmetric diabetic retinopathy. That still works, I feel. to understand that. So we had a wonderful case, second case present by Dr. Afra, where we dissected different types of macular thickening, and also we came across clinical OCT and angiographic ways to differentiate CSCR between and diabetic macular edema. And to top it up, the first case where we had a discussion about macular edema management along with cataract, where the certain points just to highlight was use of first is a strict diabetic control that is essential before we go ahead with the surgery. Topical NSAIDs definitely have a role after the surgery, and that is evidence based. The third point is about giving the injection before the surgery, that helps, and at least for anti-VEGF is the drug of choice for the panelist here. That is the next point that we have here. Shift over to steroids at certain point in time when you feel that patient is fatigued, or that helps to the patient as well to prevent multiple visits, and also has better outcome in terms of in the long term. If we see with reduction number of injections, laser still has a role in the management of diabetic macular edema, as was highlighted in this presentation. So thank you so much to all the panelists, Dr. Madan Gopalan, Dr. Chitranjan, and Dr. Samendra, and to our wonderful presenters, Dr. Aarti and Dr. Afra, and obviously Dr. Avnish, it goes without saying. So we are back here, we'll be here. Please go and subscribe to our YouTube channel and go back and have a look at this wonderful talk as well, seminar. Thank you so much. Thank you all.
Thank you. Thank you. Good night.
Good
Thank
night.
you, everyone. Bye bye. Thank you.